Got it. So that's not where I'm going to be over here. I'm going to be over here somewhere. Got it. So that's not where I'm going to be over here. Get over here. I don't think many people got to understand that this report was filed in October, and we all need to understand what the federal government said about Nevada.
Investigation of Nevada's use of institutions to serve children with behavioral health disabilities. United States Department of Justice Civil Rights Division, October 4, 2022. Table of Contents. A summary of findings. 1-2. Investigation. 2-3. Legal framework. 3-IV. Nevada's public behavioral health system for children. 6-V. Nevada children WHO are appropriate for community-based services are placed in or at serious risk of placement in segregated settings. 7A. Nevada's hospitals are a primary source of behavioral health services for children and a gateway to long-term residential placements. 7B. Nevada relies on residential treatment facilities both in and out of the state to treat children with behavioral health disabilities. 9. 1. Children spend long periods in residential treatment facilities. 10. 2. Residential treatment facilities are highly restrictive and segregated. 10C. Children and are at serious risk of entering segregated settings are appropriate for the community. 11D. Children and their families do not oppose community-based services. 11VI. Nevada's policies and practices result in unnecessary segregation of children. 12A. Children enter segregated settings because Nevada does not ensure access to necessary community-based services. 12. 1. Nevada does not make available intensive and home supports and services needed to avoid institutionalization. 14. 2. Nevada does not make available crisis services needed to avoid institutionalization. 16. 3. Intensive care coordination is not available to children who need it to avoid institutionalization. 19. 4. Nevada does not make available respite, therapeutic foster care, and other family-based supports needed to avoid institutionalization. 20B. Nevada fails to provide effective oversight and management of its children's behavioral health system to prevent unnecessary segregation. 20. 1. The state has failed to establish and maintain a sufficient provider network to deliver key services. 21. 2. The state fails to connect children with community-based behavioral health services and avoid their admission to segregated settings. 22I. 3. The state fails to ensure appropriate discharge planning to prevent unnecessarily long stays and readmissions. 22VII.IT is a reasonable modification to serve children with behavioral health disabilities in the community. 23VII. Conclusion. 25-2. After an extensive investigation, the United States Department of Justice, DOJ, concludes there is reasonable cause to believe that the state of Nevada violates Title II of the Americans with Disabilities Act, ADA, 42 U.S.C. paragraph 12,132, by failing to provide services to children with behavioral health disabilities, one in the most integrated settings appropriate to their needs. A summary of findings. Nevada does not provide its children with behavioral health disabilities with adequate community-based services. Instead, Nevada relies on segregated, institutional settings, like hospitals and residential treatment facilities, to serve children with behavioral health disabilities. Children experience frequent and lengthy stays in these institutional settings. Over 1,700 of Nevada's children were admitted to a hospital for psychiatric care in fiscal year 2020. That same year, over 480 children received services in residential treatment facilities. Once in residential placements, children stay for a long time. The state reported that children remain in residential placements for an average of 9 to 12 months. Many stay even longer. 27% of the children admitted to residential treatment facilities between August and October of 2019 stayed for over a year. This is so even though the state acknowledges that many placements in institutional settings can be avoided if children receive necessary, community-based services. And the state service system was designed to provide community-based services, including therapy, behavior supports, crisis services, and care coordination. Nonetheless, the state does not ensure that key community-based behavioral health services are available, maintain an adequate provider network for those services, connect children with services that could prevent institutional placements, or connect children who enter an institutional setting with community-based services so they can return to the community and remain there successfully. Children who have a demonstrated need for community-based services to avoid institutionalization often cannot access that care. For example, the state has a children's mobile crisis response program, but capacity issues have substantially increased the response time to crisis calls, leaving many children and families to seek care from hospitals. Data also revealed that most children in a sample of recent residential placements did not get the state's behavioral support services before or after placement. And the number of children who received intensive care coordination through wraparound in Nevada in fiscal year 2020 was less than a fifth of the one. Children with behavioral health disabilities are individuals up to the age of 21 who have a diagnosable serious emotional disturbance, mental illness, and/or substance use disorder. This population includes children with co-occurring intellectual or developmental disabilities. 1. Number of children who were hospitalized for psychiatric care that year. Lack of access to these services results in unnecessary reliance on segregated placements. State government leadership is well aware of these challenges. Regional consortia charged with developing recommendations for children's mental health services have repeatedly highlighted the lack of access to critical community-based services. The national organization Mental Health America has also highlighted the deficiencies in Nevada's system in its ranking the state's report. For the last 5 years, Nevada ranked last in the nation in children's mental health based on prevalence of illness and access to care among children. Nevada's deficiencies are exemplified by the experiences of Martin, too, a child who was appropriate for community-based services but instead received treatment at 2 residential treatment facilities. Martin had experienced abuse and family disruption as a young child and had difficulty maintaining relationships with others and controlling his anger. Not long after a psychiatric hospitalization, at 8 years old, Martin was placed in a residential treatment facility. Records indicate that he had received few community-based services prior to this admission. After 8 months at one residential treatment facility in Nevada, he was sent to another residential treatment facility in Colorado, nearly 1,000 miles away from his home in Reno. At his admission to that facility, he reported that his only wish was to not be here. By the time he was discharged 7 months later, he had spent nearly 15 months of his childhood away from family and friends. The state can reasonably modify its service system to ensure children are served in the most integrated settings appropriate to their needs. Nevada has included key building blocks of an effective community-based service system in its Medicaid state plan. The state could reasonably modify its system by expanding the availability of these services, supporting and managing its provider network to increase quality and access, assessing children and diverting them to community-based services before they enter institutions, and, for children already in institutions, engaging them in discharge planning to quickly and successfully return home. 2. Investigation on December 17, 2020, after receiving a complaint, DOJ opened an investigation to determine whether Nevada unnecessarily institutionalizes children with behavioral health disabilities. After opening the investigation, DOJ attorneys and expert consultants conducted an extensive review of documents, including individual treatment records of a sample of children who had recently lived in residential treatment facilities. Our team conducted dozens of interviews of state officials and staff. We also spoke with community-based providers, county officials, advocates, family members of Nevada children with behavioral health disabilities, and children who had received services in institutional settings. Additionally, we conducted remote and on-site visits to 12 facilities, including psychiatric hospitals, residential treatment facilities, juvenile justice facilities, and a child welfare shelter. All names in this report have been changed. 2. We thank the state and state officials we interviewed for the exceptional assistance, cooperation, and candor extended to us throughout our investigation. We also thank all of the community members, families, and children who provided valuable information. 3. Legal framework. Congress enacted the ADA in 1990 to provide a clear and comprehensive national mandate for the elimination of discrimination against individuals with disabilities. 3. Congress found that, historically, society has tended to isolate and segregate individuals with disabilities and, despite some improvements, such forms of discrimination against individuals with disabilities continue to be a serious and pervasive social problem. 4. Accordingly, the ADA is intended to ensure that qualified individuals receive services in a manner consistent with basic human dignity rather than a manner which shunts them aside, hides, and ignores them. 5. Under Title II of the ADA, public entities must administer services, programs, and activities in the most integrated setting appropriate to the needs of qualified individuals with disabilities. 6. The most integrated setting appropriate is one that enables individuals with disabilities to interact with non-disabled persons to the fullest extent possible. 7. The regulations also require public entities to make reasonable modifications in policies, practices, or procedures when necessary to avoid discrimination on the basis of disability, unless the public entity can demonstrate that such modifications would fundamentally alter the nature of the service, program, or activity. 8. In Olmstead v. LC, the Supreme Court applied these authorities and held that public entities are required to provide community-based services to people with disabilities when a. such services are appropriate, b. the affected people do not oppose community-based services, and c. community-based services can be reasonably accommodated, taking into account the resources available to the entity and the needs of other people with disabilities. The court explained that unnecessary institutionalization perpetuates unwarranted assumptions that 342 U.S.C. paragraph 12,101 B1, 442 U.S.C. paragraph 12,101 A2. 5. Helen L. V. D. Dario, 46, F.3D, 325, 335, 3D Circle 1995. 628 CFR paragraph 35.130 D. See also 42 USC paragraph 12,101 B. 728 CFR part 35 App B. 828 CFR paragraph 35.130 B7. 9 C 527 US 581 607 1999. 3. Persons so isolated are incapable or unworthy of participating in community life. 10. The court also recognized the harm caused by unnecessary institutionalization when it found that confinement in an institution severely diminishes the everyday life activities of individuals, including family relations, social contacts, work options, economic independence, educational advancement, and cultural enrichment. 11. The ADA's integration mandate applies both to people who are currently institutionalized and to people who are at serious risk of unnecessary institutionalization. 12. If a state fails to reasonably modify its service system to provide care in the most integrated setting appropriate, it violates Title II of the ADA. 13. Courts have found proposed modifications that expand existing services to be reasonable, particularly when the modifications align with the jurisdiction's own stated plans and obligations. 14. The state has a separate legal obligation to ensure the availability of community-based services provided under its Medicaid state plan. The state must ensure that state plan services are available with reasonable promptness statewide to everyone who meets Nevada's Medicaid eligibility criteria. 15. Additionally, the early and periodic screening, diagnostic, and treatment (EPSDT) provisions of the Medicaid Act require that state Medicaid programs provide children tenant at 600, 11 at 601, 12C Stymel v. Wernerd, 823 F.3D 902, 911 12, 7th Circle 2016, Davis v. Shaw, 821 F.3D 231, 262-64, 2T Circle 2016, Ashby v. Delia, 709 F.3D 307, 321-22, 4th Circle 2013, MRV, Dreyfus, 663 F.3D 1100, 1115-18, 9th Circle 2011, amended by 697 F.3D 706, 9th Circle 2012, Fisher v. Ookla, Healthcare AUTH, 335 F.3D 1175, 1180-82, 10th Circle 2003, United States v. Mississippi, 400 degrees Fahrenheit. Sup. 3D 546, 553-54, SV Miss. 2019, Hildebrand v. Levy, 793 degrees Fahrenheit. Sup. 2D 1108, 1115-16, WD Mo. 2011. A state's failure to provide community services may create a risk of institutionalization. Hash by 709 F.3D at 322, Fisher, 335 F.3D at 1182, F. Failure to provide Medicaid services in a community-based setting may constitute a form of discrimination. See also Radzyzewski v. Maram, 383 F.3D 599, 609, 7th Circle 2004. A state may violate Title II when it refuses to provide an existing benefit to a disabled person that would enable that individual to live in a more community-integrated setting. 13 C. Olmstead, 527 U.S. at 607. 28 CFR paragraph 35.130 B7. 14 C. E.G. Henrietta D. V. Bloomberg, 331 F.3D 261, 280-81, 2T Circle 2003, upholding as a reasonable modification an order requiring agency to follow existing law and procedures. Guggenberger v. Minnesota, 198 degrees Fahrenheit. Sup. 3D 973, 1030, Demon. 2016, providing Medicaid waiver services to eligible people, particularly from existing waiver funds, is a reasonable modification. Hildebrand, 793 degrees Fahrenheit. Sup. 2D at 1116, explaining that a state providing a specific Medicaid service for people in institutions must provide it for Medicaid enrollees who need it in the community. Haddad v. Arnold, 784 degrees Fahrenheit. Sup. 2D 1284, 130405, NB Flaw, 2010, Providing a service already in state service system to additional people is not inherently a fundamental alteration. Messier v. Southbury Training SCH, 562 degrees Fahrenheit. Sup. 2D 294, 344.45, Decon. 2008, finding that plaintiffs' requested service expansion, which was consistent with defendants' publicly stated plans, was reasonable. 15 C42 U.S.C. paragraph 1396A8 with reasonable promptness. 42 U.S.C. paragraph 1396A1 statewide. See also 42 CFR paragraph 435.930, 42 CFR paragraph 431.50. 4. Under the age of 21 with any services coverable under the Medicaid Act necessary to correct or ameliorate a mental illness or condition, regardless of whether that service is included in their state plans. 16 The PSTT obligation is broad, requiring Nevada as a Medicaid participant to provide comprehensive healthcare services, including community-based services. 17 Offering community-based services, in compliance with Olmstead, also improves the lives of children with behavioral health disabilities. Children served in the community frequently show a decrease in clinical symptoms, an increase in behavioral and emotional strengths, improved school outcomes, reduced suicide attempts, and decreased contact with law enforcement. 18 In contrast, children face significant harms from residential care. Residential treatment for children is associated with higher rates of physical and sexual abuse, impaired social and interpersonal development, delayed cognitive, intellectual and language development, higher rates of developmental deficits, emotional attachment disorders, and even poor health and stunted physical growth. Nationally, the rate of self-reported physical abuse in residential care is almost double that of foster care and triple that of the general population of same-age adolescents. 19 Community-based care is also markedly less costly than residential treatment. National data demonstrate that community-based services cost just 25% of what residential treatment would cost, yielding an average annual savings of $40,000 per child served in the community. 16 C42 U.S.C. paragraph 1396 D.R. 5. 17 C Rosary D. V. Romney, 410 degrees Fahrenheit. Sup. 2D18, 5253 D. Mass. 2006. T. EPSDT provisions of the Medicaid statute require, by their very language, comprehensive assessments of children with SED, serious emotional disturbance. EPSDT provisions of the Medicaid statute require provision of adequate and home behavioral support services for SED children. See also KDA v. Los Angeles County, 481 F.3D 1150. 1159-60, 9th Circle 2007, agreeing that states have an obligation under the UPSTT mandate to provide effective in-home behavioral support services to children with mental illness, but overturning the lower court's requirement that the services be bundled. Centers for Medicaid and Medicare Services and Substance Abuse and Mental Health Services Administration, Joint CMS and SAMHSA Informational Bulletin. Coverage of behavioral health services for children, youth, and young adults with significant mental health conditions. Joint CMS and SAMHSA Informational Bulletin, May 7, 2013, https://pirma.cc/r9qg-rmpa. 18 Joint CMS and SAMHSA Information Bulletin 2, https://pirma.cc/r9qg-rmpa. 19 Mary Dozier et al. Consensus Statement on Group Care for Children and Adolescents, a statement of policy of the American Orthopsychiatric Association, 84 M. J. of Orthopsychiatry 222, 2014, https://pirma.cc/qg37-npup. 20 Joint CMS and SAMHSA Information Bulletin 2, https://prma.cc/r9qg-rmpa. 5. Serving children in the most integrated setting appropriate is required by the ADA, less costly than institutional care, and associated with significant improvements in quality of life for children and their families. IV. Nevada's public behavioral health system for children. Nevada provides behavioral health services through its Department of Health and Human Services, DHHS. Responsibilities relating to children's behavioral health are divided among several of the divisions within the department. The Division of Healthcare Finance and Policy, DHCFP, administers health insurance to eligible children and families through Nevada Medicaid. 21 Nevada's Medicaid program covers community-based behavioral health services, inpatient acute hospitalization services, and residential treatment facility. 22 services for children. Among the community-based services included in Nevada's Medicaid program are crisis intervention, therapy, partial hospitalization and intensive outpatient programs, medication management, and case management services. The Medicaid program also includes psychosocial rehabilitation, PSR, and basic skills training. 23 BST, 2 behavioral support services designed to improve functioning and teach life skills. Most Medicaid-funded services are offered through private providers, but state agencies are also direct providers of some behavioral health services. For example, the Division of Child and Family Services, DCFS, runs Desert Willow Treatment Center, which has an acute inpatient hospital and a residential treatment facility, and 3 psychiatric residential treatment facilities. 24 DCFS also directly operates an intensive care coordination program called Wraparound in Nevada, WIN, and the Mobile Crisis Response Team, MCRT. In addition, DCFS runs outpatient children's mental health clinics in both Reno and Las Vegas. Similarly, 21 The scope of coverage and accompanying procedures for Nevada Medicaid are laid out in the Medicaid Services Manual. Nevada Division of Healthcare Financing and Policy, Medicaid Services Manual, https://prma.cc/u4ee-q9ta. 22 The Federal Medicaid Agency uses the term Psychiatric Residential Treatment Facility, PRTF, to describe an inpatient non-hospital setting for children. Requirements for such facilities are outlined at 42 CFR Subpart 500. Many, but not all, of the residential treatment facilities that serve children with behavioral health needs are PRTFs. In Nevada's Medicaid Services Manual, these services are called Residential Treatment Center, RTC services. Moreover, the Federal Family First Prevention Services Act uses, and Nevada has adopted, the term Qualified Residential Treatment Program, QRTP, to describe certain residential treatment facilities whose services may be financed by federal child welfare funds. See 42 U.S.C. paragraph 672K4. To avoid confusion and include the full range of facilities in which Nevada children are placed, we use the generic term residential treatment facility in this report. 23 Nevada Division of Healthcare Financing and Policy, Medicaid Services Manual, Sections 403.6C and 403.6G, March 30th, 2022, https://prma.cc/9ERD-XWCV. 24 In 2021, DCFS announced plans to close one of its PRTFs and transfer some of the population and services to Desert Willow Treatment Center. See Nevada Department of Health and Human Services, Division of Child and Family Services expands residential services. August 20th, 2021, https://prma.cc/f45w-kjub. 6. The Division of Public and Behavioral Health, DPBH, operates mental health clinics for both adults and children in 12 rural counties across Nevada. The Aging and Disability Services Division, ADSD, provides services to children with intellectual and developmental disabilities. The state government also convenes and participates in 3 children's mental health consortia that make recommendations regarding services for children with behavioral health disabilities. Each consortium represents one of 3 geographic divisions of the state: Clark County Children's Mental Health Consortium, Las Vegas area; Washoe County Children's Mental Health Consortium, Reno area; and Rural Nevada Children's Mental Health Consortium, the remaining counties. These consortia are composed of stakeholders, including agency personnel, families, and providers. The Nevada children WHO are appropriate for community-based services are placed in or at serious risk of placement in segregated settings. Most children with behavioral health disabilities can remain in their homes and communities if they receive adequate community-based services. But in Nevada, segregated settings are frequently seen as the only option for children with behavioral health disabilities, because Nevada fails to ensure access to community-based services that could prevent institutionalization. Children experience avoidable, and often repeated, hospitalizations. Children who experience this cycle of repeated hospitalizations are frequently sent to long-term placements in residential treatment facilities. Many of these residential treatment facilities are outside Nevada, exacerbating the harms of the segregation. Nevada's hospitals are a primary source of behavioral health services for children and a gateway to long-term residential placements because the state has failed to ensure access to community-based services, including crisis supports. Children and families frequently turn to hospitals as a first stop for treatment. Children often begin their path toward institutionalization at hospital emergency departments. The Clark County Children's Mental Health Consortium recently described the dynamic: without easy access to crisis intervention and stabilization services, families have been forced to utilize local emergency rooms in order to obtain behavioral health care for their children. 25 The state reported that in 2020, 4,280 children were treated in emergency departments for behavioral health conditions. There is reason to believe that this number is increasing. For example, a hospital in Las Vegas recently informed DCFS that admissions to its pediatric 25 Clark County Children's Mental Health Consortium 2022 Service Priorities Report 5. https://pirma.cc/v5nj-5rj3. 7. Emergency room for behavioral health emergencies increased by 65% between 2019 and 2021.26. The state published a white paper acknowledging that hospital emergency departments are the primary means by which people in Nevada gained access to necessary behavioral health services. 27 In 2021, a group of advocates reached out to state leadership about this issue, noting that inadequate services have led to vulnerable children experiencing extended stays in local emergency rooms, among other consequences. For example, we learned of a 6-year-old who spent 10 days in an emergency room in a hospital in Reno seeking behavioral health services. Billing data for a group of children who went to residential treatment facilities underscore the role of emergency departments as a gateway to longer institutional stays. More than 60% of the children in our sample had at least one emergency department claim related to their behavioral health disabilities. The state's failure to provide crisis and ongoing community-based services to children also results in admissions to psychiatric hospitals. The state has reported a rising rate of child inpatient hospital admissions, with an increase from 1,460 acute psychiatric admissions in 2017 to 1,721 admissions in 2020. Many of these children cycle in and out of hospital settings. One parent told us about her 14-year-old son Brian, whom she adopted when he was 4. Brian needs behavioral health services, and he has not been able to get those supports in the community. Since moving to Nevada several years ago, he has been admitted to 4 different hospitals but has not gotten the community-based services he needs to avoid more admissions. This parent told us that if she knew about the state's lack of behavioral health services, She never would have moved Brian to Nevada.
Oh,
We
really?
spoke to another parent whose 15-year-old had experienced over 14 psychiatric hospitalizations. Yet
Mhm.
another parent told us that her 17-year-old son had been admitted and discharged from the same hospital 8 times. Repeated admissions were a
Mhm.
recurring theme in our conversations with parents, children, and professionals. Children who are hospitalized are frequently discharged without needed community-based services, which then can lead to more hospitalizations. Multiple hospitalizations then frequently lead to placement in residential treatment facilities. One provider summarized the dynamic. At about the third or fourth hospitalization, they say you have to go to residential. Because children cannot access community-based services to prevent hospital admissions and readmissions, hundreds cycle through hospitals and are ultimately referred to residential treatment facilities. 26. We recognize that the COVID-19 pandemic and other recent stressors have impacted children's behavior.
Oh, really? Mhm. No, it's not tonight. Stop it. It's not gonna start it again. Let me start here. It's itching. I can just skip them out of this and go down here. In conclusion, because that's the most important thing to listen to, is what the federal government is saying about Nevada. Okay. Look, it's right here. The real meat and potatoes of all of it. So true. We start speaking again.
4. Nevada does not make available respite, therapeutic foster care, and other family-based supports needed to avoid institutionalization in addition to intensive and home services. Other services such as respite and therapeutic foster care could prevent unnecessary residential treatment. Respite services are intended to assist children to live in their homes in the community by temporarily relieving the primary caregivers. Respite services provide safe and supportive environments on a short-term basis for children with mental health disabilities when their families need relief. 55. These services can provide caregivers a break without requiring children to enter segregated, institutional settings. Many families told us that they needed respite services, but they were unavailable. State officials acknowledged the gap in a need for respite services. For circumstances where a child cannot live at home, there is a need for an alternative family setting to prevent or shorten children's placement in residential treatment facilities. Such an alternative can be either a traditional foster home with intensive services provided in the home, or therapeutic foster care, which is provided in the homes of foster parents with specialized training to care for a wide variety of children and adolescents, usually those with significant emotional, behavioral, or social issues or medical needs. 56. Nevada offers a statewide specialized foster care program for children in state or county custody, but this program does not appear to be sufficient as currently administered to meet the needs of children with significant needs. During our investigation, we learned of numerous instances of children in foster care who were unnecessarily placed in segregated settings or forced to stay in such settings longer than necessary because of an inability to identify traditional or therapeutic foster homes that would accept them and meet their needs. This has resulted in congregate child welfare settings and emergency shelters serving a high proportion of children with behavioral health disabilities. Family-based supports may be particularly needed for families with adopted children. We interviewed at least 9 parents of adopted children who were in residential treatment facilities. Staff from multiple residential treatment facilities reported serving a number of adopted children. Families with adopted children with behavioral health disabilities in Nevada may have insufficient access to adoption-related counseling and other trauma-informed community-based services. B. Nevada fails to provide effective oversight and management of its children's behavioral health system to prevent unnecessary segregation. Nevada administers its system in a way that leads to unnecessary segregation of children with behavioral health disabilities. Among the actions that result in this segregation are Nevada's failure to 1. Develop and maintain an adequate provider network for key services, 2. 55 joint CMS and SAMHSA informational bulletin, 5. https://prma.cc/r9qg-rmba 56 U.S. Deputy of Health and Human SDRVS admin for children and families admin on children, youth and families, Children's Bureau, treatment foster care, https://prma.cc/5pm2-seb 20. Connect children with behavioral health services and prevent admission to segregated settings. And 3. Ensure adequate discharge planning to prevent unnecessarily long stays and readmissions. 1. The state has failed to establish and maintain a sufficient provider network to deliver key services. Nevada has failed to ensure a sufficient provider network to deliver behavioral health services for children, resulting in a significant shortage in service providers for children at serious risk of residential placement. State agencies do not have good data on who is providing children's behavioral health services in the state, the needed capacity for community-based services, or the quality of services. High-level administrators and state government recognize that the state is failing to adequately oversee its community-based behavioral health system. The outgoing administrator of DCFS told us that during his tenure, of DCFS's quality and oversight functions were under-resourced to do the job. And state officials responsible for quality assurance acknowledged that new systems must be put in place in Nevada to adequately monitor and truly provide oversight. As a result, the state does not provide sufficient guidance on the services or providers available to children with behavioral health disabilities, as the state official in charge of children's mental health told us. Because the children's mental health system has never had true oversight or regulation, there isn't a database anywhere of which services exist. This makes it difficult for families to access services, as parents and guardians shoulder the burden of finding providers. It also means that clinicians are unable to match a child's level of need to an available service through an organized system. As one state facility official told us, if hospital staff had more information about community-based services, fewer children would require residential care. Nevada's Medicaid policies impose additional challenges on accessing necessary services by restricting service utilization and provider participation. Limitations on the amount and frequency with which needed services can be delivered create barriers for children and families with intensive needs. According to the state, families attempting to access services frequently struggle with navigating these systems and receive unexplained service denials. Furthermore, challenges with Nevada Medicaid program requirements and reimbursement rates for community-based services result in a dearth of providers who will accept Medicaid. 57. The administrator of DCFS told us that she did not believe that Nevada Medicaid, as it is currently administered, supported intensive and home services. A high-level official at DHCFP, the agency responsible for Medicaid, agreed, recognizing that the Medicaid 57 funding also impacts the services provided directly by the state. As discussed above, many important services are state-funded services. These services suffer from significant capacity challenges that impact the number of children who can be served and the effectiveness of services that can be provided. 21. Rates do not incentivize providers to offer the service. The Clark County Children's Mental Health Consortium has also recently recognized the importance of provider rates. 58. Due to the lack of providers, parents are often unable to find behavioral health services for their children, or even providers who can evaluate children for behavioral health conditions. Parents also struggle to find providers that are culturally competent and speak the same language as the family. The provider shortage leads to waits of months or even years for assessments and services. This dynamic results in a crisis-driven system with missed opportunities to intervene when children present as needing help, sometimes resulting in emergency room admissions or hospitalizations. One parent told us that she could not find a provider who was taking new patients when she was concerned about her son's possible suicidal ideation. The same parent, when seeking a counselor for her daughter, searched for 4 months before she found one. Another parent told us that when her child was discharged, the parent was unable to get her child into outpatient therapy before her next hospitalization. 2. The state fails to connect children with community-based behavioral health services and avoid their admission to segregated settings. The state also fails to intervene at critical intervention points to connect children to community-based services and prevent their admission to segregated settings. Nevada does not oversee the process to approve treatment in residential treatment facilities to ensure that, where possible, children are diverted from residential treatment. The state does not assess children seeking authorization for a residential treatment level of care funded by the state's Medicaid program and connect them to community-based services as an alternative, whenever appropriate. However, a high-level state official told us that it is the state's role to assess and divert children away from residential treatment. Nevada also does not analyze data or information to learn what factors are driving residential placements. The state does not systematically assess the reasons why children are placed in residential treatment facilities. Without fully assessing why children are placed in residential treatment facilities, Nevada will be unable to prevent future unnecessary placements. 3. The state fails to ensure appropriate discharge planning to prevent unnecessarily long stays and readmissions. The state fails to ensure appropriate discharge planning from hospitals or residential treatment facilities. Insufficient discharge planning can contribute to longer than necessary stays and readmissions to hospitals or residential treatment facilities. As a state official acknowledged, discharge planning is critical to children's success upon return home. For state-run facilities, however, discharge planning is generally limited to making appointments with psychiatrists and therapists. Staff at out-of-state residential treatment facilities told us that the state does not participate in discharge planning from those facilities. 58 Clark County Children's Mental Health Consortium, 2021 Status Report 13, https://prma.cc/835q-exuk. 182. Parents of children receiving treatment in psychiatric hospitals, residential treatment facilities, detention centers, and emergency child welfare shelters overwhelmingly reported receiving insufficient assistance planning for and coordinating services to help their children avoid another hospitalization or residential placement. Indeed, stakeholders report that children are frequently discharged without medication or proper community-based services, which can cause a worsening of their symptoms. Compounding this, Nevada does not follow up with children who have recently received residential treatment to verify they are receiving community-based services or track outcomes. VII. IT is a reasonable modification to serve children with behavioral health disabilities in the community. States must reasonably modify their service systems to avoid discrimination on the basis of disability. 59 Nevada could reasonably modify its existing community-based programs without fundamentally altering its current system to prevent unnecessary segregation of children with behavioral health disabilities. Such modifications would allow children to live and thrive in their own homes and communities instead of entering or remaining in institutions to access appropriate care. Nevada has established many of the basic components of the service array that can prevent unnecessary institutionalization for children with behavioral health disabilities, if offered throughout the state at the intensity level required to meet these children's needs. For example, Nevada provides mobile crisis and care coordination to some children. In addition, the state has included components of intensive in-home services in its Medicaid service array. Nevada officials have acknowledged the importance of these services for children in preventing institutional placement, and they have expressed an intention to expand them. Indeed, Nevada has created specialized programs to address its deficient community-based behavioral health system, but these programs are limited in scope and insufficient to address Nevada's overuse of segregated settings. 60 Courts have found that expansions of existing state programs are reasonable modifications, especially when they are consistent with the jurisdiction's plans and obligations. 61 59C20 ACFR paragraph 35.130 B7 I Olmstead v. LC 527 U.S. 581 607 1999 60. For example, Nevada recently created 2 new specialized mobile crisis programs, C-Supra and .45, which are limited in the number of children served. In 2020, Nevada also received approval from CMS for a paragraph 1915I state plan amendment regarding children's behavioral health services. However, the paragraph 1915I is a new program that is focused only on children in specialized foster care and covers fewer services than the state acknowledges are needed. Nevada also has a federal system of care expansion and sustainability grant that aims to improve services in the rural regions of the state. Nevada has also invested in certified community behavioral health clinics in an effort to expand behavioral health access throughout the state. However, state officials told us that the program is currently serving few children. 61 C-Supra N.14. 23. Nevada spends significant resources on hospitalization and residential treatment for children with behavioral health disabilities. Publicly reported data shows that Nevada spends approximately $11,000 per child for each month in a residential treatment facility. From March 2020 to March 2021, Nevada spent a total of over $38 million on residential treatment facility services for children. 62. We reviewed 5 years of Medicaid claims data of a random sample of children who had received treatment in residential treatment facilities, and we found that over 80% of spending on behavioral health services for these children was for hospital or residential services. Because community-based services are less expensive than residential services, shifting spending toward community-based services is both reasonable and more cost-effective. Additionally, as noted above, the early and periodic screening, diagnostic and treatment (EPSDT) provisions of the Medicaid Act require that Nevada's Medicaid program provide children under the age of 21 with any services coverable under the Medicaid Act necessary to correct or ameliorate a mental illness or condition. The state must provide these services, including community-based behavioral health treatment, to the extent they are medically necessary. 63. Though Nevada's Medicaid program includes some community-based services, many children who need the services to avoid institutionalization cannot access them in sufficient intensity to meet their needs. It is a reasonable modification for Nevada to provide these services in the amount medically necessary, given the state's pre-existing obligation under the Medicaid program. Nevada could serve children in the most integrated setting appropriate to their needs and comply with Title II of the ADA by reasonably modifying its service system. Remedial measures should include ensuring that community-based services are accessible and available with sufficient intensity to prevent unnecessary institutionalization. Services the state should ensure are available and accessible include intensive and home supports and services, intensive care coordination, crisis response, peer support, therapeutic foster care, and respite. The state should consider input from children and families with lived experience in expanding its service array, ensuring that the array of services is available statewide as required by Medicaid. The state should adjust rules and procedures to facilitate the participation of children's behavioral health providers in Medicaid. The state should conduct a rate analysis of its Medicaid rates and adjust its rates if needed to allow for robust provider participation in community-based behavioral health services. 62 Nevada Division of Healthcare Financing and Policy, BHS, Out-of-State Residential Treatment Center Report 6. https://pirma.cc/by5n-fshj 63C 42 USC paragraph 139060 R5. 24. Exercising robust oversight of community-based providers. The state should ensure that community-based behavioral health services are of sufficient quality to allow children with significant behavioral health disabilities to remain in their homes and communities where appropriate. Assessing children at serious risk of institutional placement for community-based services and quickly connecting them to appropriate services. The state should assess and connect children and families to services when needed, such as when they experience a crisis, are referred to WIN, are hospitalized, or are referred to residential treatment facilities. The state should closely manage the process of improving residential treatment, including by examining data associated with residential admissions to make system improvements. Working with children and families when a child enters a segregated setting to facilitate discharge and transition back to the community. Discharge planning work should begin at admission. The state should ensure that children have access to sufficient community-based services upon discharge and that discharges are not delayed by inadequacy of services. VIII. Conclusion: for the foregoing reasons, we conclude that there is reasonable cause to believe the state fails to provide services to children with behavioral health disabilities in the most integrated setting appropriate, in violation of the ADA.64 because of deficiencies in its community-based service array and the manner in which the state administers its children's behavioral health system. The state relies on segregated settings to serve children with behavioral health disabilities who could be served in their homes and communities. We look forward to working cooperatively with the state to reach a resolution of our findings. We are obligated to advise you that if we are unable to reach a resolution, the United States may take appropriate action, including initiation of a lawsuit, to ensure the state's compliance with the ADA. Please also note that this report is a public document. It will be posted on the Civil Rights Division's website. 64C 42 USC paragraph 12,132, 28 CFR paragraph 35.130 D. 25.
I guess that's the end of it. In conclusion. Yeah, that was in conclusion. So. We're still stuck, right? We're hearing how they don't have enough people. Let me see what's happening. Stop sharing the screen. And share one more time. Lots of things. Well, all I can say is you need to get online and go to the USA.gov and figure out how to help yourself because that's where you are. That's where we're living in America. I think I'm going to go for now, but I'll be back. Y'all have a great evening. Eat purpose. How many days? One, but I'd want. And maybe more. What do you want to do in 2023? Like, subscribe, and follow me. This is Darlene Anderson.